Today we do something special. I will go through a couple of cases inside the virtual MSK fellowship, so you will get a little bit of a glimpse on how it works. People are posting their own real MRI cases where they have specific questions about something, and I will answer that question for them. So let's jump right in here to the first case submitted by Emanuel, and he's asking whether there is a TFCC tear. So we have a little bit of a history. Is there a tear in the triangular fibrocartilage disc? There is no associated edema at the level of the radius. And the question is there a complete tear in the scapholunate ligament with dissociation between the two bones, partial tear of the FCU tendon, and would that explain the pain in the ulnocarpal compartment or in the fibrocartilage region? And this is the case. So let's dive right in. Now, I haven't seen any of these cases before I opened them here, so it's kind of like the first time I'm going to have a look at them. So I will probably stumble upon a few of these cases as they tend to be sometimes quite tricky, and you can see how I solve these cases in real time. And I think it's sometimes nice to then also be able to follow the thought process that I use to actually solve such cases, and this has proven to be very helpful for many people in the live Q&A session, but also inside the virtual MSK fellowship in general. So I just need to make sure I put this in here. So this is an anonymized case that he submitted, and we know that there is pain on the ulnocarpal side. So I typically don't really go through the whole case unless I have to because of time reasons. So I want to focus mainly on the ulnocarpal compartment here. The first thing we can see, there's a little bit of a dorsal subluxation by the aspect of it. So we can see the center of rotation is somewhere here if we would draw these lines over here. So I think it's dorsal here at the transition of the second and fourth, or second and first quarter of this line. So it's a bit of a dorsal subluxation, something we can think about, although to some degree this can also happen in asymptomatic people. As for the prosthesis osteoarthritis ulna, we can see it's on the lateral side. So this is pretty much a neutral position otherwise, with the ECU tendon here nice in place without any tenosynovitis or abnormal changes. Now these internal bands here, these are not true split tears or something, especially in the ECU tendon. There are even histopathological studies that show that these are just some fibrovascular bands inside the tendon structures. We can describe them. Maybe if they reach the surface, we can start to think about something like this, but most of the time these are asymptomatic. So we can just keep that in mind. We describe it, but we don't really judge it. We've got some fat saturation issue here on the thumb level, but we don't really see any edema. I don't think this is a true edema. I think this, again, with the adjacent changes in the subcutaneous fat tissue. I'm also thinking this is just a fat saturation issue, but no real edema. And this one here, which is a PD fat set, PD fat set, PD fat set. So there's no stir. And on the T2 star, well, we wouldn't see edema much anyways, so it's not a real edema. So let's focus on the proper TFCC. The TFCC, I typically start central, so we want to see here, and you can see the great thing, I can use this drawing tool, so we can see the disc here in the center. We can see the cartilage coming down, so this here is the cartilage, this lighter stuff here, and this is still the disc that's attaching to the cartilage, so that's still okay. And here, this is the level of the volar radio-ulnar ligament here. We only see one part, and then it goes away because the slice thickness is quite big. Then on the ulnar side here, again, we can see the insertion of the dorsal radio-ulnar ligament here to the bone. I think is good. This here, this gap is not a gap. It's, again, the disc inserts onto the cartilage from what I can see on these. We can check here. Again, this is much nicer to see the cartilage, attachment, cartilage, still cartilage, and attachment, bang. Okay, so I think the disc itself looks okay. What's the age? Just want to make sure I'm not getting the age wrong here. This is a 38-year-old. Okay, so the disc itself has no perforation. I don't see any substantial irregularities based on this resolution. Then we have the normal foveal attachment. I wouldn't make a tear out of that here. I wouldn't also give this as edema. I think it's too subtle, and we didn't see anything really in the other planes in this area here. So we just say it's normal. And then for the styloid attachment, which we don't really see often on just one plane, so we just want to make sure we scroll through a little bit here, and then also on the axials. So it's probably here part of this this structure here that comes over, and you can see it's touching down here. I think that's also intact. Again, same for the dorsal radio-ulnar and volar radio-ulnar ligament. So I don't think there is anything wrong with the TFCC. We also have no effusion or evidence of synovitis in the distal radio-ulnar joint, and also not really in the radiocarpal joint, although there is maybe a little bit of an effusion, but I think it's not enough to really be concerned. We have this fluid pocket here. So one is the pre-styloid joint recess, another ganglion cyst, and the other one will be the pre-styloid recess. I think there are just these two recessi which are fluid filled, but not really concerning anything else there. And then I think there's a good point that Emanuel did here for the FCU. There is a bit of an irregularity here where we have a caliber change and even a tiny calcification potentially inside the tendon, some irregularity also of the pisiform itself, but potentially there is a little bit of a, so this is not normal. And it's not, so the dark bit here is also not fat on the fat saturated image, and we got a little bit of edema around this structure. I want to see this on the sagittal here. You can see this also here. So this is the vessel, I think, but the vessels is just next to it. We can see this here. These vessels here are just partial volumed in. So we go to the next slice, not this one, this one, this one. So here we can see here this edema, this is actually real. This is at the level of the insertion of the flexor carpi ulnaris just before it actually attaches to the pisiform, and it's at least some tendinosis. Maybe there's a tiny calcification which could be from hydroxyapatite deposition, although it's still dark here on the T2 star as well. So I think that's the cause for the ulnar-sided wrist pain. TFCC fine, so I'm suspecting some tendinosis, potentially calcification at the FCU or just proximal to the FCU insertion into the pisiform, and with some perifocal edema, which would raise the suspicion of hydroxyapatite deposition disease, or to be more specific, calcific tendinitis in this case. I would recommend the radiograph. I just want to see this on a sagittal, on a lateral radiograph to see if there is actually a calcification. And they can also just easily palpate it if it's painful, just to see. But we can see there's just something irregular going on here. If it's not calcification, then it's maybe just a little bit of like, maybe even thinking about a partial tear, chronic potentially, or something going on here. But I think there could be a little bit of a calcification here, even if we don't. Yeah, we can even see it here on the T1 as a dark thing. So I would go with calcific tendinitis here. Okay, so, oh, damn it, I forgot to actually record the case for him. So, but it's not a big problem. So we're just gonna, so normally I do video answers. So basically whatever I told you right now, I would give as a video answer. So we can just type in, hi, TFCC is intact. Maybe mild dorsal subluxation, but I don't think that's relevant. Great pickup regarding FCU. I think there might be a calcification. See images with perifocal edema, which would raise the suspicion of calcific tendinitis. I would recommend a radiograph or correlate with one if already been done. Okay, so just gonna answer like this. Sometimes I do like this, but the next one I will do actually use video. Okay, so great. Let's go to the next case. I think I am recording. I'm a bit confused. Yeah, I think it's recording. Okay, so let's go to the next case. So this was this case. Okay, so we did this. So let's go here to this case by Maria. So Maria, she didn't upload the full case. I think she might not be allowed. So, but let's read the history. Nodular synovitis or chronic Anserine bursitis. So it's a 66-year-old woman with psoriatic arthropathy in treatment with immunosuppressants and knee pain, and I've seen insufficiency fracture in the tibial plateau and complete radial tear of the internal meniscus root. So that makes kind of like sense. My question is, what is the hypointense pseudonodular 12 mm structure between the internal tibial plateau and the Anserine tendons? Can it be nodular chronic synovitis, chronic Anserine bursitis, PVNS? And the X-ray apparently is unremarkable. So we can see this is a great case actually, and this is something you need to see only once and then you know it for the rest of your life. So Maria, you're in for a great learning opportunity here. And yeah, you made the arrows. I just want to go through all the images so that we can see. And it's so great because everybody has the same questions. The better you get, you start to see new things pop out, and then you have new questions, and then you answer them, and then you have the next question, etc. And I've been at these stages before, that's why I can just easily answer this question now. So we keep it with this image here. This is part of the semimembranosus tendon insertion. It can sometimes be quite nodular in appearance because it's the part of the semimembranosus tendon that comes down and then goes anterior. So the semimembranosus tendon has multiple arms, and this is, I think this is called the direct or anterior arm. I always have to look this up. So semimembranosus tendon arms. We can just go any of these images here where we want to see how they have these different parts. This one, I think, it's a bit, so this is from behind, so this would be the anterior arm, whereas the direct arm goes kind of like straight down, but I just want to have maybe better graphics than this. Let's see if we find something better. Here, this one, semimembranosus, so this would be the number 3. So let's go here, let's go to this page, and let's go to direct head of semimembranosus. So anterior of medial tendon of semimembranous. So the anterior arm, and then the direct one goes straight down. So anterior arm, like I initially suspected. So this is the anterior arm. I can also go here, anterior arm semimembranosus. Oh wait, before we do that, I just want to now make the proper recording for my fellows. Okay, so that's how I normally do it. Okay, so hi Maria, thanks for this interesting case. Now this is a great example, and you will only need to see this once. This is often, you see this occasionally, it's not very frequent, but it's a thick part of the semimembranosus tendon insertion, and because it's a bit higher in signal in both sequences, it's tendinopathic, but it's the direct arm of the semimembranosus tendon. And I can show you this here. So this is this number 3 direct or anterior, sorry, not direct, anterior arm, sorry, I said it wrong. It's the anterior arm of the semimembranosus tendon that comes anterior to our image. So we can go here, anterior arm MRI. So I just want to show this here. Here, this one, distal semimembranosus, this would be the direct arm. We can go here. We go just for the images, sufficient, not this one. So they measured a few things. And here, this is just a signal increase, but it's part of this structure that comes anteriorly to our image. So they don't really show much here, so that's not a great article for this to show. This is again from the same article. But yeah, anyways, it's the anterior arm of the semimembranosus tendon, and it just jumps out sometimes as a separate nodular structure or mass-like, but it's just a part of the tendon. And you can follow it here also nicely. It comes down and goes anterior. And the semimembranosus has multiple arms. One is the anterior one is the direct one, then there's the inferior one. I think 5 or 6 of those, and some smaller attachments to the meniscocapsular junction. And this is basically the anterior arm. And in this case, it's a bit thick, so a little bit of tendinosis there. Okay, so this is it. So now back to the video. This is how I answer the question. Short 1 or 2 minute video, sometimes 3, sometimes 4 or 5 minutes, depending on the complexity of the case. Because I normally don't see these cases beforehand, I have to solve them in real time, also doing all the literature research that I do in real time if I have to. So, and then what I do, I just go here, I go to Maria's case, and then it's the anterior arm of semimembranosus tendon insertion with tendinosis. So that's it. So now she can watch this video and then she has the answer to her case. Okay, so let's go to the next case. Next case here, sacroiliitis, again by Maria. So 37-year-old male, clinician. So let me just start right away with the recording. Okay, so record. And let's go here. Okay, so we got the male, clinician wants to rule out sacroiliitis, HLA B27 positive, CRP positive, and the lumbar spine is not much going on, bad quality. You see erosions and some subchondral sclerosis, no edema, synovitis or capsulitis. So grade 2 with no active signs on MRI. Okay, so let's have a look at these images. Obviously, I would prefer the original images, but that's just, I think, 1 or 2 of the 300 people in the program who are not able to do that. Yeah, so the image quality is not the greatest, but we can see there is irregularity at the iliac side on both sides, which looks erosive. The joint space is sometimes a bit wider, and here, especially this one, is an erosion. Here we've got erosions there. We don't really see any active inflammation going on, so that's that. So we can go to the next image, and this is just I would assume the slice behind it. And again, here we can see the same thing. Yeah, so this is consistent with erosive or structural lesions of sacroiliitis, both sides, but no active inflammation. And I would not give any gradings. I don't think that's required. The plain films I don't think we really need it. So there's maybe a little bit of sclerosis here, but I wouldn't really, at this point, it doesn't matter, to be honest, because we have the MRI already. And then here, what is this? Here, this is now more the synovial portion of the joint, where we can see in the inferior portion still these changes, which are erosive, as you already suspected. So great, so we just go with that, and yeah. So, basically the message is consistent with sacroiliitis, with structural lesions, erosions, but no signs of active inflammation, which obviously would point out that this can go into, or is a spondyloarthritis case. Okay, yeah, so this was a nice example here. Let me just, it's uploading the video, we don't need this one, and then I'm gonna post this here, copy link. So I wanna try the next case to be, so erosions of just sacroiliac joint without active inflammation, then chronic sacroiliitis. And the reason why I write it here is because the platform school that I'm using for my teaching has a search function. So if somebody wants to search for chronic sacroiliitis, they will find this post at any point later down the road. So then we have another case here by Emanuel again. So let's just also do the recording and get rid of everything else here and start. Zack, record. 3, 2, 1. Okay, so right hip due to Piriformis syndrome, and you don't see anything related to Piriformis syndrome. Bursitis of the iliopsoas tendon, osteoarthritis of the hip, joint diffusion with synovitis, alteration of the normal morphology of the femoral head. Is there alteration in the normal morphology of the femoral head? So these are his questions. Is there insufficient coverage of the acetabular roof? So this plastic acetabulum. Is there synovitis secondary to coxarthrosis? And can bone deposition disease coexist? Are there any signs? So this may be a translation error, and there are any signs of marrow reconversion. Okay, so let's go right into the case. While it loads, I'll have a sip of coffee. So I think we want to start with the Piriformis syndrome. There are articles that look at MRI of Piriformis syndrome, and the main thing that they found, and it's basically one of my one of two criteria I use, is the size of the muscle. And it has been shown that the muscle, the piriformis muscle, tends to be bigger on the side of the suspected piriformis syndrome. So in this case, we only really have the axial, which don't really go all the way up. Here it looks symmetric, and on the coronal T1, also the piriformis muscle looks symmetric. We don't really see a proper mass or anything like there. The second thing that I would look at is the sciatic nerve, and see if the L5 and S1 and these different distributions have a transmuscular run through. But here we can see that the nerves are coming down, piriformis, and there is nothing that's going through the actual muscle. So there's no evidence of a piriformis syndrome, but it's more like by exclusion anyways. And since we've got a massive finding here, it's not a piriformis syndrome. So okay, yeah, so we got the ellipsoid bursitis, absolutely right, here on the right side with this ballooned thing here. We've got a little bit of an effusion in the hip joint, as we can see here, as opposed to the other side. We've got bone marrow edema on both sides of the joint. We have got joint space narrowing, so we got osteoarthritis here also. I don't think it's under coverage per se, from what I can say here on the corona. Let's see here. I think the acetabulum has, well, if you look at the center, maybe there is a little bit of a mild dysplasia as opposed to the other side. I think you're actually right. So we would not count the osteophytes for the measurements, but if we were to do the lateral CE angle here, although we have a cam deformity here, the lateral CE angle here would be something like, we can just measure this. I don't know, I would not measure the labrum, and we don't want to measure the osteophytes, but so we can still do something like this and then have a more or less a straight line. So we come up with around, so depending on, so technically you would do the perpendicular to the both lines, but this is just approximation, 2021. So it's kind of like borderline dysplastic here. Acetabular coverage, but we've got also cam, we've got osteophytes formation, and this is now at a point where this could be from chronic femoral acetabular impingement with the cam deformity, and we can see subchondral cysts, cartilage loss, joint space narrowing, and joint effusion, etc. So the synovitis will be a result of the osteoarthritis. Pretty sure cartilage loss, you can see there's pretty much zero cartilage. It should be the same as here. So we can see there is a nice cartilage here at the posterior aspect of the joint, and it's completely gone here in the weight-bearing aspect and also in the anterosuperior one. This is where the cam deformity bumps up and makes the labrum and everything mushy. So, and this one here is, so it's not just bursitis, because many times, not many times, 10 to 15% roughly, the bursa has a communication with the joint, and it's more prevalent in cases with joint disease. So here we can see a wide opening between the iliopsoas bursa and the joint. So basically the joint effusion gets decompressed inside the bursa. And the reason for that distension here is now most likely the effusion of the hip joint that gets decompressed inside the bursa, rather than a primary iliopsoas bursitis. But this is something that we cannot really be sure 100% because there might still be bursitis. I would just describe this as there is distension fluid in the bursa with a communication inside the hip joint. You can see it here nicely, likely decompressing the joint effusion inside the bursa, the primary bursitis or additional separate bursitis. So that's how we can give both ideas. Yes, so that was the question. Yeah, the head is abnormal because it's cam deformity, as we can see on the sagittal typically also, and osteophyte-rich formation. But this is the bump. You don't have any radial images, but I think we can see on the T1 here that the head-neck junction is nice and smooth on the other side, and here it's kind of like flat and bumpy. So this is the anterosuperior cam. That will not be helpful in this case. Insufficient coverage. I would say it's borderline dysplastic, but it's not the main or sole cause. I think it's a consisting cam issue in this particular case. The other thing we can check if there is any retroversion. Well, this is not a true axial. I would need a true axial for this. You can also see if we go from the top, so we can see here, this is the first image of the posterior wall, first image of the anterior wall. So we also have a retroversion of the acetabular at the cranial aspect, which can lead to sometimes a small focal over coverage, but obviously with a borderline dysplastic hip, it's probably not such an important thing as it balances each other out. But generally, by the aspect of it, it looks undercovered rather than the opposite. So yeah, so I would just say borderline dysplastic. But yeah, this also contributes to the osteoarthritis development. And so what else was the question? Synovitis to osteoarthritis? Yes, pretty much sure. Or can bone deposition disease? I don't really know what you mean with bone deposition disease. Maybe is it hydroxyapatite or CPPD or something? I wouldn't worry about any of that at this point. There's no evidence that there is some additional thing going on now at this point. And signs of marrow reconversion. So the age, I think was, we just want to verify the age, 49. So it's elderly. Yeah, so this is just a bit of a red marrow, which is normal. So in this age, I would just say, maybe it's a woman. I think it's normal for the age also. I would not even mention this. It's not really jumping my eye. Maybe she's a little bit anemic, maybe she's smoking. You can just say like a lot of red marrow, indicating like a increased use from smoking or anemia, or maybe because she, I really don't know. I think it's a woman, right? But we can check. No, it's a man. Okay, it's a man, so it's not a woman. Anyway, so yeah, we can describe this, but I don't think it's relevant. It's symmetric, and the T1 is still nice. It's not the same as muscle, so we're not worried about the marrow infiltrating process at all. Okay, so you saw this was now a 7-minute video. Sometimes I go quite extensive here. I could have said this in much less time, but sometimes I get carried away. Okay, so this was another case, and then we copy this in here. I don't give much comments here. This is no, this is the wrong one. Hang on, this is the wrong one. Wrong link. This is the wrong link. It's not 1 minute. I'm gonna give you the right video. Yes, 7 minutes. That's better. Okay. Okay, let's go here. We got another case, this time by Greg, and this is about PCL in the knee. And let me just again make sure I am recording this properly. Okay, so yeah, hi Greg. So we got a young person, 18-year-old, misstep while running. So no major trauma, and review from another institution. My impression, high-grade PCL sprain, partial thickness tear, adjacent posterior capsular sprain, mild strain of the lateral gastrocnemius muscle, and I don't see ligaments of Risberg or Humphrey, and suspect they are torn. And the interpreting radiologist, the first one thought it was a tear of the popliteofibular ligament, which you think is okay, unusual to see such a significant PCL injury with not much else to see. Okay, so let's have a look at the case. Young person, 18 years old. I just want to put everything in. And it's recording, yes. Okay, excellent. So yeah, trauma, and we can jump right into the PCL here. We can see the PCL is clearly abnormal, substantially so. It's thick, it's irregular, it has irregular contours, and some of these fibers, they really look disrupted here. So we want to have a look at the other parts here. So we can see at least this fiber here, this darker one here, that one seems to go through. So some of these fibers are still going through, but we will not rely just on one single image, right? So we want to really go and look also at the coronal. We can see this is now the origin here. We see these fibers, it's thick. And then here, the more posterior aspects here, there is a few of these, at least one or two of here are still going through, whereas we can see these munched up fibers here and here, they are looking torn. And then on the axial, we do the same. So we go through all three planes to assess this. We can start distally this time. We come up here, even here, this is normally a nice black structure, right? So we can see that, oh, this is not looking great. It's kind of like bulging out here a little bit. And because where's the joint capsule? The joint capsule is coming here. It kind of like goes in, it's bulging out. And then, but some of the fibers are still going through, yes. Yeah, I agree. I would give this a high-grade partial tear. And the history, we don't really know the time delay, do we? So, but this must have been recent, and it's a young person. So we're not suspecting any pre-existing mucoid degeneration. So we just go with a high-grade partial tear. That's what I would say in this case. And obviously this will create some perifocal edema and hematoma here. And for the joint capsule, we can see a few other findings here that we can now go through. Okay, so let's go here quickly through the whole joint. So we can see medial meniscus here is fine. I don't see any cartilage defect or bone marrow edema, just a little bit of here, the posterior aspect of the medial femoral condyle. MCL is fine. There is no Baker cyst, and the pes Anserine tendons are fine as well. And like in the previous case, in the first case here, this is the, or second, this is the semimembranosus anterior arm here, which is a bit less prominent than in the first case, but this is normal again. Okay, so let's go to the lateral side. Lateral, we can see the posterior root is okay. The meniscus, we want to see the sagittal. Where is the sagittal? Here, sagittal here. Anterior horn, body going back is fine. We don't really see the meniscofemoral ligaments, Humphrey and Risberg, which can indicate that they are torn. It's not proving that though, just to keep that in mind. Some people don't have big ones, but yeah, we don't see them. I would just say that they are not visible. And then we have the meniscopopliteal fascicles here. So anterior inferior one, supraposterior one, posterior inferior one down here. And then we have the popliteus tendon. And then we've got a bit of edema here at the level here, which we can better see on the coronals. So we can see the proximal tibiofibular joint. This one here is part of the anterolateral ligament. The lateral collateral ligament is fine. And then we go back here. And here in the posterolateral corner, this would be part of the popliteofibular ligament. And there is some periligamentous edema. I think a sprain would be in order here, connecting this. So you could even argue this one is the part of this attachment here from the popliteus tendon all the way to the tip of the fibula here, either here or here. But you know, it's even, you can even go with a partial tear. I wouldn't go with a complete tear, but I think partially torn here is okay. Not that it matters much, as we have established already that the lateral collateral ligament is okay, the biceps femoris tendon is okay, and the popliteus tendon itself is also okay. So just having a little bit of edema here around this structure could indicate that there is something wrong. But you can see there is part of it is joint capsule. So because you can see this is opening into the joint here, coming here, there's an attachment to the tibia, and then somewhere here could also be the thing. So I want to go back here. So this is again this line here that we saw with the perifocal edema. And you can see there's also some strain here of the soleus muscle origin. And so I think you suspected the lateral gastrocnemius muscle to be involved, but the lateral gastrocnemius muscle is actually the anterior bit. And this muscle here, that's the soleus muscle origin, which has a strain. And if we have a strain here and there is hematoma, then obviously it will also go around the capsular ligamentous structure of the popliteofibular ligament complex and proximal tibiofibular joint, which then could look like as this was affected as well. Yeah, because it's not an ACL setting here, we can still call it like a sprain or low-grade partial tear of the popliteofibular ligament if you want. I'm not sure if I would have done it without you mentioning it at all, but at least I would call the strain of the soleus muscle origin. Meniscopopliteal fascicles are fine. And yeah, so I think that's for the lateral side. Now, there's no avulsion fracture, no. So now ACL is fine. So ACL goes through, okay. And the next thing we want to look at is the, what's this? Oh, it's just some fat lobule. So the next thing is the patellofemoral compartment with normal cartilage. There's a mild effusion or a moderate effusion rather. It's a bit more than mild, is a moderate effusion, and we got the extensor tendons and half of fat bed normal. Yeah, high-grade partial tear. And you can also give, because of the edema and hematoma in the popliteal fossa outside of the joint, we can give an additional sprain of the popliteal capsule, strain of the soleus muscle origin, and then some hematoma around the popliteus tendon and popliteofibular ligament, indicating potentially a partial tear. Although again, I don't think it's clinically relevant. In this case, the relevant finding is going to be this one. Okay, very interesting. I don't think we missed anything. The only thing is, to me, this looks a bit weird here, as if this was bulging out. I want to see this again on the sagittal. just something that jumps my eye when I go through this case, as if there is something cutting in here into the joint capsule. But we can see the other parts of the popliteal joint capsule here, the popliteal oblique ligament and these things, they are still all in this area here. So what we've seen here before, so we can see the joint capsule attachments here. This is further down. And just want to go here. Lateral meniscus. This is already bone. Yeah, it looks a little bit weird. That it's kind of like something looks like indenting into the PCL here, or maybe it's just the two parts of the PCL that we can better see, and a little bit of the joint capsule going in there. This is the popliteus muscle, joint capsule. Yeah, it's not going to change now the interpretation. I would maybe also not even describe it, because it's just an interesting observation here that we see it maybe better. Maybe if we get the next knee in this run or in this video later today, then we can have a look at this region in a normal knee. Okay, so that's it. So you saw, sometimes I don't know all the answers, but I think we can answer a few of these questions here for Greg, and I just want to let it upload. And sometimes I also do this like this, so I can find it later very easily, or just name it as PCL high grade partial tear. So I can find these cases, and also the fellows can find these cases better. Okay, very good. So let's go to the next case here. Oh, I already answered. Okay, so Ritish has just given me feedback, so that's good. So that's a case that I already answered. Now this case, we have an answer by Esteban already, and here we have another case that I already answered. Yes, offset is flat, then you can use it. But if you have a typical cam deformity, so it's a subtle distinction between offset and cam, but yeah, we can still separate it a little bit or make a distinction. Here we have oh yeah, this was the osteochondroma case in the pubic symphysis. Marlene also commented on here, so we had a good discussion about this. I also think this one is solved. Knee ossification by Gustas, so let's go to this case next. So before we then start, and also before I do the recording, I just want to have a look at the PCL capsule relationship here, because that was a bit strange in this previous case. So do we have as axial? Okay, maybe the 3D, it's not so well. Maybe, yeah, just let it load. We can use this one already. So we saw previously that there was something indenting this thickened, partially torn PCL, and I think it's actually part of this joint capsule. And you can see maybe there is some part of the joint capsule that are actually blending in with the PCL. And in the previous case, we had this was torn. We got one here. We got a little bit of this in here on the other side, maybe just because it was a swollen piece of ligament, but the true joint capsule also still goes around here with some pericruciate fat pad or fat tissue all around here. So the actual joint capsule goes here, and then we've got these additional strands and stuff, which we can maybe even see on the 3D. That would be nice. So we can see, we go down, and you can see how the joint capsule here blends in, and then we have one of the posterior layer here, and then we've got this other layer here. And I think it's just in the previous case, the thickened PCL just bulged into this, but I think it was on the medial side, right, wasn't it? So yeah, we can see there are these different bands of, or different layers of the joint capsule. Okay, so, but let's go to this case. Somewhat interesting case with an ossification of the patellar ligament. This is, I think he doesn't have a question, he was just sharing here. So we can see this large ossification here. So this is most likely from a chronic old Osgood-Schlatter disease. Do we see susceptibility artifacts? Oh, I wonder if we can see some susceptibility artifacts. I don't think there is a specific question, but it's kind of like a very extensive Osgood-Schlatter disease with edema, subchondral cyst formation with these multiple fragments, even one fragment above the tendon, so basically just encasing or semi-encasing the patellar tendon here, and certainly being looks painful. Yeah, so very interesting case here. So just there's no specific question. Old Osgood-Schlatter disease. I don't think there was another question than this. Okay, so let's go to the next case, which is a ACL reconstruction case. Okay, we get quite a few of those after ACL reconstruction, because that's a topic that many radiologists struggle with and have questions about it. So let's see if we can help in this case. Oh, I don't think no, I'm not recording at the moment. It's good. So 1, 2, 3, 4, 5, 6. That's good. So here, let me just start the recording. Yes, zack. Record. Okay, so Ritish is asking about this post-ACL reconstruction with a medial meniscus ramp tear and or repair even, and this has been done 17 months ago, so 1.5 years, a little bit less, and has now pain for 5 days and 2 episodes of giving way in the last 2 months. No history of recent trauma, looking or crepitus. And the question is the graft having a high-grade partial tear? Is there fibrosis or Cyclops anterior to the graft in the anterior interval, posterior aspect of the Hofer pad? What are the loose bodies in the posterior joint space superiorly? So we're going to look there. There is a horizontal fluid signal in the posterior horn of the medial meniscus. This is a tear or a grade 2 change. I think it's separate from the repair side. Okay, multiple ACL reconstruction. Okay, so Ricardo already answered, but before I want to read anybody else's answer, I'm just going to go through the case for myself. Okay, I'm getting tired. Ooh. Excuse me, I should finish my coffee. Okay, so ACL reconstruction, let's jump right into the ACL here. And we can see there is one screw here, we see the tunnel here. I think first thing we can see is tunnel position is fine. The next thing is it's nearly 1.5 years, so between 1 and 2 years we start to see normally a ligamentization of the graft. I'm recording this, which means the graft should slowly turn back to normal, and here this is nowhere near normal. First of all, the orientation of some of these fibers are a bit, wavy. It's thick, and it has this additional bulging out component here, which is a small Cyclops. So I think that's right. And this is consistent with this one here. And then we've got these darker bits, which are likely susceptibility artifacts, but the graft integrity is not great. I would also say, given the signal and given the laxity of some of these fibers, that we are looking at a partial tear of a degenerated graft with Cyclops formation or focal arthrofibrosis. And even on the axials, it's, this area looks rather thin with some fluid-like pockets. So yeah, I think partial tear with a degenerated graft. Positions of the tunnels is fine. So what could it be? Is it a graft impingement, or just most likely it's going to be some form of graft impingement. And also here on this ACL series, we can see this nodular piece of soft tissue here, which is consistent with a Cyclops lesion. And then the graft is just irregular. There's no real structure to it. And then we have these two nodules back there, which have quite a close proximity to the origin of the, or not to the entrance of the graft. Here, I wonder if these are parts of a torn graft. And do you have a radiograph? So I would be curious to see, well, you wouldn't see anything on the radiograph anyways. T1. Because these two bits, they don't look bony. I don't think this is a bone. It has pretty much the same signal as the graft. So I wonder if these are parts of the torn graft. As they also seem to have like a connection here to the entrance, and the graft becomes thin and then thick. So maybe these are torn parts of the graft which are retracted and flexed. So we want to see this on the coronal again, and we want to window this a bit differently. Like from here, like it looks like could be part of the graft. Was this a hamstring graft? Let's see. We don't really see much in terms of the donor side. We don't see much where they took it from. The pes Anserine tendons look quite unremarkable. Okay, but it looks weird. So the differential would be it's an ossicle, but for this to be an ossicle, I would like to see some substantial cartilage defect. And on the main area, femorotibial compartment, we see some smaller cartilage fissures maybe here, but there's no large cartilage lesion. And also patellofemoral joint really doesn't give us the impression of a substantial osteoarthritis or anything like that. Yeah, so I'm worried that this is part of a retracted, partially torn component of a graft, either from a hamstring, maybe it was from the contralateral side or whatever they took it from, because it has pretty much the same signal, and the graft has caliber changes, and it has this funny, especially on the sagittal, it looks like it's connected. It has these linear bands that look like it's a bit like a ring with a little neck here to this. Okay, so I think that would be it. I think there is high-grade partial tear with this funny structure, which either is some form of debris, the differential would be debris or some form of synovitis, but parts of the torn graft. I think it's most likely parts of the torn graft. Good. So, and then there were other questions. These were the ones you meant. This one we answered, this one we answered. And then the horizontal fluid signal in the posterior horn of the medial meniscus. So let's go there, because we know they did a ramp repair. You can also see there's a tear of this vesicle here. But anyways, let's go to the other side. Do we see any susceptibility artifacts? I don't really see much. So I think this is the fluid-like thing. Because fluid is inside, this is a bit more than we would expect from just vessels. I would actually call a little horizontal tear here. It's not really reaching the surface, but here, this is likely where we had the meniscotibial ligament avulsion. So this tiny piece of meniscus here from the meniscotibial ligament has been avulsed, and I think they probably did here some suturing or something. And this is where fluid goes in. Fluid shouldn't go in after a repair. Even here, this looks a bit irregular, but this could still be post-operatively, I think. And here, I would say there is fluid entering in this horizontal cleft at the posterior medial corner or posterior medial transition of body and posterior horn, which is consistent with a re-tear. You could easily compare this if you have with the prior exams. So if the previous exam shows, in addition to the meniscotibial avulsion, which we assume, an additional horizontal tear, then we would think about the re-tear. And if this wasn't there before and this area of the meniscus looked super nice and this was just the only thing, then it would be consistent with a new tear. And that's how we do it with arthrograms. So after meniscal repair, we do sometimes, in rare cases, an arthrogram, and if contrast leaks in, then it's per definition a re-tear. If it's a linear change, let's maybe say like this, and it's pre-existing, then it can just be consistent with post-op changes. So there's sometimes we use that as a distinction. Okay, so again, tricky case. I think the stuff back there was a bit tricky. Okay, let me just copy that. And then here we go. Yes. Graft ossification. Yeah, I didn't look at the anterior drawer test, so it's subtle, but there's a little bit of a step off, especially on the lateral side. So anterior drawer test. So this is the answer by Ricardo. Question could be a small one. Yes. Loose body spot would come from. Yes, I think that's the differential. Either it's loose bodies or this part, because it's too big. I think it's part of the graft. And horizontal tear, yes. I agree. Okay. So I'll give him a like. And this should be the answer to the case. No, that's not right. It's not the right link. This happened so many times. Edit. I just want to go back and fix this. Okay. I just double check the link. Yes, that's the right one. Okay. Good. Next. Elbow. So here we have an elbow case. Interesting. And let's start the recording. Record. Okay. So Gustavas has a female, 53 years, left elbow. Don't know even how to describe the findings in the area that the radial nerve passes. Could use some advice on the description and ultimately what this could be. So again, before reading any answers, we want to open the case. We're looking at the radial nerve where it passes through the supinator muscle. I just need to put this the right way. I don't know why this is not everywhere the same. Okay, so, all right. Oh, yes, very interesting. This is interesting. So let's start with the normal anatomy here. So when we go at the top, we see radial nerve, we see median nerve, we see ulnar nerve. So we follow the radial nerve down here. We can see there is another fascicle here. It branches off, and so we got these different neurofascicles here. This one is a bit high signal. We got perifocal edema, thickening, and this looks scarred and everything. And then here, this would be the part of the radial nerve, the deep branch, which is too thick. It's neuropathic. It comes out here. And then we've got this other stuff, and this is the superficial branch. And we see a subcutaneous change that goes through the muscle. So this looks like a postoperative case after some form of release of a supinator syndrome or radial tunnel syndrome or something like that. So I want to see if I can see any susceptibility artifacts at all, because obviously that would be good, but we don't see any, which is curious, because why would it be like this? I think that it's got to be a surgical thing. Do we have this information? No. Okay, do we have this information here? No. Okay, very interesting. So my first idea would be that somebody already did something there. But if it would not be the case, so we follow the radial nerve, we can see here this one, or this was, I think this might be the vessel, but you can see the radial nerve is this area here. It goes down, it branches off. We got these two main branches here. This is the deep, this is the superficial one, and the deep one enters the supinator muscle, and from the entrance, even before that, it's too thick, it's too hyperintense, and then only becomes normal down there. And on the coronal, we should be able to see this as well, or on the sagittal here. So this would be this is the nerve, neuropathy of the radial nerve, ramus profundus, or deep branch. And then so weird that we have this perifocal edema. Either they did, the other thing, maybe they didn't do surgery, but maybe they did a like these neurological tests where they have the nerve conduction studies, and maybe he poked around a little bit there too much. Interesting though that we don't have any denervation edema of any of these muscles. That's interesting. What else would we have to think about? Some form of a mass, like a fibrovascular or hamartoma kind of like change here. that would be the other thing. Do we have contrast? We don't have contrast. And this is the T2, which doesn't really give us much more information either. Like there is fat in between. I don't see a distinct mass, and I see the nerve structures going through that thing. So it's more like diffuse edema here with something going on there. Yeah, so let me just go back up again. I'm trying to see the vessel. So that's a vessel. So this one here is the vessel, and we can see it's branching out to the vein. It's a vein here that goes beneath the nerve. And this is the vein. This is the nerve. Okay, it branches out. Some of the smaller branches are then there, and this the two big ones. And this is definitely the nerve. We don't have any higher resolution than this. Do we have an axial T2? Axial T2. Oh, that's the same as down there. Yeah. So in conclusion, what would I say? I would say there is marked thickening and neuropathy of the deep branch of the radial nerve passing through the supinator muscle, and even thickening and signal increase proximal to this here all the way up to the humeroradial joint space. The superficial branch has normal caliber and signal, but there is perifocal edema at the level of the branching off and in the adjacent musculature all the way with quite a linear approach through the, what's that? That would be pronator teres. Which side are we on? It's the owner side. No, it's not. Brachioradialis muscle, so we can check. Emanuel's great tool. If you don't have it, I think you need it. It's really amazing. It's really good. So again, so this is we don't need this. We want to briefly check the muscle. So brachioradialis muscle, like I said, and you can see the two branches together, then branching off. This is from top to bottom, branching off. In this case, this is where we have all the edema also in the muscle, and then the deep branch goes through. The other one goes there. So yeah, so neuropathy of that deep branch, perifocal edema most likely from recent nerve conduction studies, or potentially like a focal contusion, or I don't know, like somebody stabbed him with a knife, or like, you know, I think we need to have some clinical information here because it goes all the way to the skin, so they know. Let's see what they came up with here. Radial nerve passes. Neurologist suspects compression at the level of the elbow. Okay. I would say there is edema on the perineural soft tissue bifurcation. Yeah, that's the brachioradialis muscle, and this is where Ricardo get the amaios for more. Yes, very well done. Nice, thickened. Okay, great. This is great. So he got it. So let me just stop this here. It's very beautiful. I wonder why we don't see muscle edema. So maybe it's too early, or I don't know why. Or maybe they have more distal issues. And if it's coming from a neurologist, I think that's also a sign. Would ask if they did nerve conduction study with the needle to check nerve electricity, or however we say that in English. It's neuropathy of deep branch of radial nerve. And there's a great article, radial nerve compression MRI, I think on Ratsource. It's not posterior interosseous nerve. Well, because I think they have the corresponding thing. So here you can see atrophy of the muscle, and this is basically what happens. The illustration here, arcade of rows, and this is where the stuff gets compressed, but often with denervation edema, which we don't see in this particular case. I'm just gonna post this here. strange that there is no denervation edema. So sometimes in radial tunnel syndrome, it's not always with denervation from what I remember. MRI, yeah, they don't say. Okay, so maybe it's either not there yet or I don't know. Anyways, unusual to not see the edema. Unless they would have injured the nerve with the injection, but I don't think that happens. And yes, interesting case. So let me just stop this here. Yes. This is the recording. I'm gonna enter this radial nerve deep branch. Neuropathy, maybe after nerve conduction study. Copy link. Okay, good. Lovely case. Excellent. So 659, that's the right one. So let's go to Vasilin's case. It's another ankle, or the first ankle for today. Let me start the recording for Vaseline. No, this screen. 3, 2. Okay. So you can see that's what I do all day. Not all day, but maybe 1 or 2 hours a day. So ankle distortion 8 months before, after conservative treatment, still pain and instability, difficulty walking, presupine, the Taylor chondral lesion and bone fragments. Thanks in advance. Again, we're not going to read it and we go straight into the case. So whenever I have a case with chronic pain after an ankle injury, I want to make sure I'm not missing any fascial avulsions because that's quite often the case. But let's see. I'm not saying this is the case here. Maybe not. Vaseline would have seen it. Okay, so yeah, the Taylor dome is a question and the bone fragments. Okay. Yes, I mean, we see a large subchondral cyst. We see a osteochondral lesion here of the lateral talar shoulder or dome. We see there's an indentation, the missing piece of bone or osteochondral defect even with this large cyst formation, which is basically with this cartilage fissure and then subchondral cyst formation and so on. We can also see this here. This is on this side. So we can measure the superficial, basically in 3 dimensions we can measure this. It's quite a large subchondral lesion, deep focal cartilage defect, cartilage fissure, most likely even undermining and delamination of cartilage here through this, like this. I think it's just a resolution issue with then a subcortical break and interosseous cyst formation. Even here, like loss of the subchondral plate. Here, okay, so this is basically just the osteochondral lesion of the talus that we would describe. We can see there's no effusion or synovitis. And you mentioned something about the fragments. I think this is mainly on the lateral side where we can see here an ossicle here where the ATFL is just very short here. So this is most likely after a bony avulsion of ATFL, as we don't really see anything else that's remotely like the ATFL. So this is anterior syndesmosis going down, 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 down. Ossicle, tiny short ligament here from a bony avulsion. Let's go to the lateral here. This is the avulsed fragment. And yeah, that's just what it is. And then we see very nicely the LFC here, very nicely seen. It's a bit thick, maybe a bit of scarring of the LFC. You can see it's very thick and scarred, but it's in continuation here. This is the bony avulsion. PTFL is going to be fine, some scarring and bony proliferations here at the insertion of the deep deltoid fibers, some additional small avulsion fragments here, a lot of scarring also going on without complete loss of striation. And also the superficial deltoid ligament looks a bit scarred and thickened, whereas the spring ligament complex, the supramedial band here, looks unremarkable here. And also the 2 plantar components here and here, these ones, they are okay. Yeah, what else? So what's going on? We can see some fatty atrophy of abductor hallucis here, and some also fatty changes in the intrinsic musculature distally. So maybe there's some additional polyneuropathy going on. So we need to check also the tarsal tunnel. We go up here, we see tarsal tunnel, we come down, tibial nerve here. Well, it's a high division of, I think this is the medial and the lateral plantar nerve already divided. No, this is muscle, sorry, that's muscle, too quick. This is tibial nerve, we go down, 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 down. So we've got lateral and medial plantar nerves. There's no mass, just some veins here, varicose veins can sometimes compress the nerves. But this is a marked fatty atrophy here. This could be from different reasons. So basically we just describe it at this point. We don't see any subacute denervation edema. The lateral nerve, the signal of the nerves itself is normal all the way up here. So we don't have any evidence of a neuropathy. And maybe there is some more like, maybe there's some edema here also. So maybe it's either some form of chronic polyneuropathy, because we also have these changes in the distal portion here. And the patient is how old? Maybe it's diabetic, 53-year-old. Could be. So maybe there's some underlying polyneuropathy, which I would suggest, or not suggest, at least put into the game. Yeah, so I think that covers most of your questions. If you have any other specific questions, Vasilis, then let me know. I'll answer these again. Okay, yeah, it's a bit unclear. Let's see what Ricardo said. Given size. With displaced fragment. No. I agree. The fragment is from old ATFL avulsion, not from the OCL. Because that's not how it works. It's too big, it's adjacent to the ligament, exactly at that location. There's no effusion, and we don't really see a missing piece of bone. Even this one here is just the osteogonum. Okay. But yeah, I mean, it's good to think about it, that potentially it could be osteochondral fragment, but it's not the case in this particular case. And time was 4:51, that's the right case. Okay, so Ricardo, finally your own case. Let's see, Ricardo, another ankle case, and we want to start the recording. Yes, this one, check. So Ricardo, spring ligament, also ankle sprain, spring ligament, supramedial portion partial tear. It's a good question. Tibio-talar fibers of the deltoid ligament, sprain or partial tear. That would be the deep portion. Thank you in advance. Lovely. So let's jump right in and let's make all the series on the screen. 1, 2, 3, 4, 5. Okay, so it's not loading. Oh yes, it starts. Okay, so ankle sprain, and the question was the spring ligament area. We can see there's some bone bruising at the medial talar and medial navicular bone, and maybe some flattening and subtle bone bruising of the plantar aspect of the talar head. So there was some injury in this location, and on the coronals we can see another, like here, so maybe there was some form of a supination injury where we have a bone bruise also on this aspect here. Okay, but for the spring ligament, I typically start on the axial. I think it's the easiest one. We start at the top. We can see there is scarring. I think this is an older injury. This is not an acute one. This is more subacute to chronic already. We see thickening and scarring. This is way too thick. Like, this is not the normal appearance of the deltoid ligament insertion. It's also going maybe higher up. So maybe there was some form of periostal stripping back when it started. Here this is just abnormally thick. Let me just see on the sagittal if you can see. So you can see this is not normal, and we can suspect that there was some deltoid ligament injury at the time of the initial trauma, or maybe even like acute and chronic, like an old injury with some scarring here, and then it goes down into tibia spring, and then we see some signal changes here at the tibia spring ligament. We want to see that specific portion on a coronal. So we go down into the supramedial component of spring ligament, which is this one here. This has a normal signal. It has a normal shape. Now this distal portion, there is always a thin strand and a little bit of edema. This is basically everybody has it. I would not be too sensitive. Maybe because the edema is a bit more, we can maybe go with a sprain. I wouldn't call a partial tear though. Maybe here also the edema here, so we can give a sprain of the medial plantar oblique component here, especially because of the adjacent bone bruising. But the supramedial portion here, I wouldn't give a partial tear per se. I think this location here, this often looks like this with a thinning portion here, and I think this is just not yet the complete ligament. So let me just go down here to this area here. We can maybe there, yeah. So maybe we can give a little bit of a sprain, but I will show this in another example here just in a second, where we are not looking at the spring ligament injury. But yeah, this is a bit of edema, maybe a little bit of a sprain here at the supramedial and inferomedial plantar, plantar, what's it called, like the inferomedial plantar component, right? Sometimes I forget. Okay, then some edema here, and I think there was another question about the deep deltoid fibers. So again, the deep deltoid fibers, they are not very edematous. They have this lower signal stuff in here. Some of the striations we can see, but this looks more like scarring. Maybe here's a tiny partial detachment here, but the other bits and pieces, they are intact, but it looks scarred after older injury. And then here, maybe if we want to give a small partial tear or avulsion at this location, I think that would be okay. I wouldn't do more than that here. And then on the coronal here, okay, so here, this is now the interesting bit. This is the deltoid ligament, tibial spring, and this is supramedial spring ligament, and this is the tibial spring here, which has a bit of an irregularity here. So I think at this level, I think we could give a low-grade partial tear. This often looks more smooth. We often see a caliber change, but I don't think the signal change, the signal increase rather, should be there. But again, the lack of perifocal hematoma doesn't make that an acute injury. This is more like in this subacute stage, or even subacute and chronic, I would believe. So let's go back to Vasilin's case, because that was the last ankle we saw. And I just want to compare this so that we can directly compare structures where we were not looking at specifically these changes. And here you can see the tibial spring typically is more black and nice, so we can go back to the previous case and say, okay, look, this is a bit abnormal. This looks, it's not super fluid-like, but I think this is a more older injury, a mold partial tear or focal degeneration of tibial spring after an old trauma. And the other bit was on the axial PD facet, so we go here. And here in this case, it's nice. This is now because the pole comes quite close. There's also, if you look at the tibial spring, it's a bit of a thinning, but not as marked as in the previous case. So that it's one way how we can maybe think that this is maybe then a tad too much, but also because of the signal, not necessarily because of the thinning. This is just joint capsule anyways, but ligament only comes further down. But yeah, so at least a sprain or a high-grade sprain, not sure if I would call a partial tear. The orientation, etc., looks quite nice, but at least the sprain, and then maybe this more like scarring and irregularities of the tibial spring itself as well. I want to see this now on another ankle as well. Let me just go, because I want to just see another ankle, just some random ankle mass. Yeah, a mass. That's good. Let's take a mass, because they don't have any injuries, or they didn't have one. 60-year-old, similar age. And we can have a look at how it looks in this particular case. Oh no, it's not loading. Let's see, okay. So you can see also here, there's a bit of a signal increase, a bit of thinning. Here, this is still normal. Well, this is just an older lady, maybe it's just a chronic little bit of irritation, but this is now very sensitive. Let's take a younger ankle. Let's see, 45, 19-year-old. Okay, oh no, that's not a good. Well, the image quality, I think it's not great image quality, but we can still try. It's not the best image quality, but we want to see on this one. Again, you can see there is a bit of a higher signal, even if it's not torn. And we want to have a nicer ankle than this. Let me just go a bit more back in time. Yeah, so that should be a good case. This was a trauma case, and let's see. Let's load it up. We use the axials primarily. We need to window this. Oh, this is not a good example. This is now exactly with a severe injury where even the spring ligament is injured. So funny. Okay, it's loading very slowly. But yeah, I mean, you can see the, now it's there. You can see this is now partially torn. Like, this is not normal. And I can also show this on the coronal whilst we're at it. So you can see this is partially torn. It's an acute injury. We want to go back to a different one. And ankle Shridut. Yeah, let's take Shridut's case, maybe 45. Just get rid of some of these cases. That's the last one I try. But again, this one also has on the medial side some issues. No, this is the lateral side. So now this is a funny orientation. So let's try a proper ankle somewhere. Maybe that's one of my ankles. Okay, let's take this one. Non-specific, no trauma. Okay, let's try this one. They have nice images there. Is there even a radiograph? It's only a radiograph? No, there. Diffusion, no, we need no fusion. This one. This is post-contrast. We can use the 3D if we download it. We can use the 3D and just, did they reconstruct it? No. So we can just do it ourselves. Axial, okay. You can, again, you see sometimes these higher signals here and this, some model thing. This is not a true, we need to have the orthogonal, or maybe this one even better. Sometimes they just flip it a bit like this. So you can see it's just sometimes a bit brighter there. But yeah, I think from what we can see now, it's a bit more than what we would like it to be. This is now the very last one. I think I'm not going to find a lovely case where I can highlight what I want to say, because maybe I'm also wrong. There's no axial even, okay. Okay, I'll let it go. Let's go back to the actual case at hand. This is not this one, I think it's this one. No, it's not this one, here. Yeah, so yeah, I think it's a bit too much. So I'm now more inclined to even think about a partial tear of the distal portion here, because I think it's a bit too bright here. Let's check the Chopard joint. It's not a Chopard injury, is it? No. And distal portion here together with the, where's the coronal? Yeah, I think here this is just before the insertion. Yeah, so yeah, let's go with a partial tear. Good. And then the sprain of the medial plantar component. I need to spring ligament component. Sometimes I forget component. I forget sometimes these silly names. Supromedial plantar oblique. Yes, because it's running oblique. Medial plantar oblique. Okay. This one. Okay, so we can see these two components here, and this medial plantar oblique. So basically, the location of the insertion and the run is sprained here, and I would not go with a partial tear because of the axial. We can still see the striation here. And then we can give maybe like a focal partial tear of the distal insertion of the supromedial band. I think, yeah, that's probably where I would be heading, especially because of the bone marrow edema here. But I just want to mention that just caliber change is not enough. A little bit of high signal here is also quite frequent and not typically relevant or symptomatic by any means. Split tear, peroneus brevis, and some other bits and pieces. Okay, that's just way more time than I actually wanted to invest for this case. But yeah, I think Ricardo was actually on a good, it's very good here. So good to see him getting the stuff right. Okay, just want to copy this. And then we go back here. Now we go here. Just need to find his case. Ossification, ankle instability. Oh no, where is it? PCL. Shoulder out. Alexander, knee, ankle sprain. Here. What's this? Vasilis keyboard. Okay, good. And then knee lesion. Okay, soft tissue lesion in the knee. Let's see. Oh, I need to be quicker. Let's speed it up. Record. Okay, so Gustas has a case, 37-year-old female, knee lesion. Question, what could it be? Let's jump right in. It sounds like a mass somewhere, and we want to see the mass. 1, 2, 3. Even with contrast. Okay. Yes, very, very interesting. So we can see there is kind of like this bag of worms. It looks like a bag of worm. We have a phlebolite here with the low signal on all sequences, even on the T1. We have this large vein that goes right into this area here also. It has a subcutaneous component, or it runs partially inside the vastus lateralis muscle, mostly inside the muscle. It's not subcutaneous, but it has a deeper component in the subcutaneous tissue. And with the phlebolites, maybe there's another one, or at least some of it is fat, maybe here. And you can see some fat in between, which gets suppressed. So we have component of fat, vascular structures. This is a slow flow venous malformation. We don't see anything like phloboids or anything that would indicate that this is a high flow lesion. We can see the feeding or draining vessel here into the popliteal vessels, and then some other feeders here through the vastus lateralis intramuscular components. So yeah, that's a slow flow venous malformation, and sometimes they use it as the term that was used is soft tissue hemangioma. But it's not a hemangioma per se, but it's a slow flow venous malformation. You can see the multiple fluid levels. We see phlebolites. And just because we see these levels, I would not think about a like some soft tissue ABC aneurysmatic cyst or something. I think with the feeding vessels, this is, when with the phlebolites especially, there is not much in terms of differentials other than a slow flow venous malformation. And you can also see the sedimentation here after contrast. It's enhancing. The behavior is like vessels, so it's a vascular lesion. Okay, that's a quick one. And let me just check out the phlebolites and feeding vessels, and then copy link. 2 minutes. Okay, this is the schedule update that I did, and then we have Shridut with a case. Okay, then we do record, layout, record. Okay, hi Shridut. So, hi Shridut, we have a case here, 30-year-old female, knee pain, current patellar dislocation, moderate diffusion, well-defined focal lesion at a very low signal intensity at the medial patellofemoral recess, nature of lesion, focal PNS. So that's your question. Mild blooming on gradient, mucoid degeneration, ACL, PCL, buccal, no meniscal tear, lateral patellar dislocation, ATFL intact, Inza Salvati ratio, no patella alta, trochlear dysplasia, please opine, thanks. Okay, so this is the case. Yes, it is 30-year-old female. I'm looking at a structure in the suprapatellar recess medially here, this big thing, and which is low signal in all sequences. and apparently there was a patellar dislocation, for which we don't have much evidence. So we have a little bit of a hypoplastic medial facet, but it's not too bad. And as you said, we don't see an MPFL tear. We got a fusion though, and the signal kind of behaves a little bit like cartilage on most of these series. If you look at the signal intensity of it, it's similar to the cartilage on all these lesions, on all these series here, and even here on the sagittal. And you didn't give contrast. There's no really blooming inside the lesion either. Okay, so in terms of differentials, what I would think, given the fact that we had this history of patellar dislocations, the differential would be that this is a large, I'm just thinking, is a large cartilage body, although much larger than anything that could get displaced from the joint. Like the thickness is way higher than what's normally available to dislocate. For it to be a piece of thing that just grew is a bit unusual, because as a young person, it would be a long-standing thing. It has a funny shape for something that would have grown organically from a small cartilage chip. So I'm thinking potentially it could also be just a blood clot, like from a hemarthrosis from a more recent dislocation. What is the history again? History patellar dislocation. Okay, so yeah, is she having recurrent dislocations? Potentially so that were the two differentials. More likely I think would be a blood clot, even if we don't really have a lot of susceptibility artifacts. The second differential would be that it's a large piece of chondral body that has grown substantially, because we don't see a donor site. I don't see a donor site. I don't see a donor site, which makes this a bit less likely, but I think given the signal characteristics are in keeping with the cartilage on all the series, I think that's the differential. So either that or the other one. Contrast will not really help. I don't think it's going to enhance. I don't think it's PNS based on the gradient that you did here. We could still do a contrast study maybe in 3 months, or even like if you want to be less, maybe 6 weeks, because if it's a blood clot, it would be smaller. If it's still there and it's not enhancing, then it would be like a loose body, like a cartilage body. If it's enhancing, then it would be a funny mass thing, like some form of nodular synovitis. But I think the signal is a bit too low, or some form of nodular fascicular fasciitis. There's some funny intraarticular nodular fasciitis. These are low signal stuff that would not enhance. But yeah, I think the follow-up will clear this up. I don't think a ultrasound at this point will be helpful. I think the next thing to do would be the follow-up and see how it behaves if it gets smaller. The question is, why is she having the fusion though? Like, was this more like a recent dislocation again, and she has just a lax, chronically stretched out MPFL, and the more recent injury has led to the hemarthrosis and this coagular blood clot production? I think that's probably the most likely scenario in this case. Okay, so that's a bit of a, it's not a guess, but I think that's be my approach. These were the two main differentials. I'm not thinking, given the shape, that it's a tumor. So I want to have the link. And now this is a typical example where I would like to request, I think, blood clot or cartilage body, although chronic and grown from a initially small chip. I think MRI in 6 weeks to 3 months would be good, and if it shows a resolution of the mass, it was a blood clot. When was the last dislocation though? As a fusion is not explained otherwise. A fusion. Please bring back the follow-up scan if possible. Okay, so then he can upload the follow-up scan and we all will learn something new. Okay, so let's go to Alexander's case. Alexander has a case. Good. 37. Yes, seems not to be a good age. 37. Lots of injuries at that age today. And we want to record it for Alexander as well. Okay, so countdown 3, 2, 1, go. Yes, ATFL after trauma, female, 37, high ankle sprain 1 week ago. Is there bony avulsion of ATFL at the talus attachment? Thank you. So pretty straightforward question. Is there a avulsion of the ATFL at the talar insertion? And we can see ATFL is torn off. I think we see a bit of edema here also at the presumable insertion, and it could be that this low signal stuff is a small cartilage, not cartilage, like a small bony cortical avulsion. I think that's probably also very likely given the fact we see some subtle changes in the bone too. The T1, I don't think this will really help us, to be honest, because of the, first of all, patient moved and resolution. But given the fact, I think this is very likely to be a small cartilage, small cortical avulsion of ATFL. I would probably dictate it also like this because it's a linear structure. It has this Schallenförmig, like this, what's it called? Bowl, not bowl, like a plate-like appearance. I mean, like it's not round like this. It has this moon or crescent shape here, and it's likely a piece of cortical here that's got avulsed. Yes, so I agree. Very good, question answered. And you see, I'm only answering the question they have because there's no point in going through stuff they are not interested in. I want to keep it high yield and people get quick iterations on stuff they really want to know. And if you then look also at other people's questions and get such answers, this is really great because it's what I call exponential learning. It's the most efficient way to learn quickly a lot of things because everybody has the same questions. Like I see also other people asking the same questions that I answered 2 years ago, 1 year ago. And obviously they can't go through all of the stuff, but we keep repeating the same thing and everybody picks it up so quickly. Okay, here we have a 70. I think that one I answered already. Oh no, I haven't seen it. So she posted the case. Let's open the case. Because initially the case link was missing. And this is a... Okay, let's record this case by Anastasia. Go. Okay, hi Anastasia. We got this old lady and eccentric focal high signal at the femoral diametaphyseal region, vertically oriented region at the lateral part of the represents red marrow. Any other suggestions? You performed some additional Dixon. I think this is another study of the same case with the Dixon imaging, and you're suspecting, I think, red marrow or rechecking. Okay. Dixon is performed today. I think drops out on opposed way, although it's a bit hard to tell because the lesion consists of a thin periphery. Perhaps still red marrow, but more concentrated. Could it be NOF or absolutely not in that age? Okay, so let's go to the first scan. I think this was the first scan and this would be the Dixon imaging. Yes, so let's start with the first one, even before we have a look at the Dixon. We don't often do Dixon in our institution. So let's have a look here. It's about this lesion here, presumably. Let's see, lateral, distal. Let me just verify location. High eccentric, high signal, femoral, vertical oriented. Okay, yes. And I think it's this one, and then on the axial, this one. It's essentially here. So this looks like a little bit shrimpled. It doesn't have a sclerotic border. The first idea that I would have is that it's either some residual thing from a non-ossifying fibroma or potentially a bone marrow infarction. I don't think it's red marrow. The signal doesn't really fit on the T1. So these tiny islands here, this is red marrow here. This one is a bit too irregular, too low signal. Given the shape, I'm not thinking about something sinister. And so let's go to the Dixon that you did. Not sure if that will really help us, to be honest. and the T1 wipe, that might be better. So you can also see centrally there's a bit of fat or going inside the lesion, and I'm still thinking more that this is a infarction, either a small infarction or a residual piece of NOF, and sometimes they can be also in elder people. We can still see some changes of it. I don't think I get anything out of diffusion imaging. Yeah, so that's my suspicion here. Either a small rest of marrow infarction, not quite typical, or a NOF. So I think that's the case, but it's definitely not red marrow. Okay, let's put it this way. Okay, so maybe enough. Then we got Ben as a case. Okay, so let's go to Ben's case. A hand. We didn't have a hand yet. Well, we had one TFCC, but let's see what this is about. Let's start here. This one. This one, yes. Start recording. Okay, hi Ben. So you have a case. It looks to me like at least part of the extensor digitorum muscle tendon has been severed, and there is a tendon stump retracted to the level of the distal ulnar joint. This appears to be next to a separate intact extensor digitorum muscle tendon. So does this mean the EDM is bifid and only one of the tendons has been severed? I think EDC5, extensor digitorum communis 5 is intact. I must admit I haven't encountered many of the cases where it's the focus. I never looked at it, but since it's the case, I've reviewed a few random cases, and the tendon seems not uncommonly to be bifid or bifurcate around the level of the wrist insides. Okay, so interesting case. So we can see here yeah, I think we can see these two things. First of all, we see there are two pieces in the fifth extensor compartment. We see this is the sixth extensor compartment, fourth, third, second, first, and we see two slips, and then the bigger of the slips here stops, and then the distal portion goes, and in between we have a lot of fluid, so there's tendinosis, and then this one goes all the way here. We don't see what here. There is a bit of irregularity too, so something happened here. What's going on? Let's go to the sagittal. So you can see there is a focal edema. Either I don't know whether this was a punching injury or what did they do? Laceration. 3 months ago, laceration of the dorsal fifth MCP region. Okay, so there was some form of laceration here, and at this level we still see part of the two tendons. Then zack, gone, a little slip and the retraction here, and then the two down here. So that's interesting. Yeah, extensor digiti minimi, coronal here. We can see the stump retracted with a little bit of a, I think this is just a little bit of a coiling here, retracted to this level. So we need to measure this. Where it is, you described it nicely. We give the distance to its insertion, and the other bits and pieces here are going through. So they might probably go and do something about it, and still see some changes here, and we see the origin. So this is the tear. Basically, it's exactly how you said. Now the question, and I think that's a good question, is it a bifid slip or is it or what's going on? So I will probably also go now into the literature, and we can briefly do that. So extensor digiti minimi tendon. So we just want to go here, and we can also use Emanuel just to see a hand. And I think you did the right thing, going through a couple of cases, get an understanding of the number of slips we see. That's also what I would do. We just go here, do it like this. We can see here also 2 slips. And I think that's it. So we want to go back here, extensor digiti minimi. They show it only as 1 slip here. Extensor digiti minimi. Oh, so that was not extensor digitorum muscle, but extensor digiti minimi. Now I understand. So insertion action. So can be bifurcated or split, and there's no reference, but I'm sure we find one. Extensor digiti minimi tendon variance MRI. So we're just gonna go here. Anomalous with multiple slips. This is from 2023, and yeah, you can see the bifurcation or with multiple slips. This is not even a radiology paper. A high resolution of the fingers. And here, this is an older one. Let's go here. Clinical anatomy. And so conclusion. Okay. Let's see. No. Okay. The retinaculum. So they looked at the retinaculum. Only one specimen had one extensor digitorum minimi tendon, while 71 had 2 slips. And so the majority actually has 2 slips. And so that I would just go with that then. So we have a complete tear of one of these slips with retraction out to this point, and the thinner slip is still continuous, and then we see the origin of the proximal sac from here after this laceration here. We measure the gap, we measure the retraction, and what I would suggest, if you hand tendon zones, use the zones to describe these things. They have different zones for flexor and extensor tendon, so we can basically extensor tendon injury, we use this like this. So injury in zone 5 with retraction of the proximal stump all the way here to the, well, it's basically, but it's zone 8, right? So if you only use this, so it's zone 8. So from 5, and then you measure the gap, and then the hand surgeon has all the information he needs and understands immediately what you're talking about. So use the zones for the extensor tendon injuries and also for the flexor tendon injuries. Amazing. So this is a great case. Thanks for bringing this up. And I want to copy this in for everybody to see. Okay, that's the information we want. I want to post this in, and I want to give also the reference. And we want to go here, and this is our recording, and zack, zack. All right. Yes, so we got here shoulder. I think this one has been answered. Oh yes, no, I didn't answer. So let's go to Sridut's case now. Let's close all this stuff. So recording. Start recording, and let's go. 60-year-old female, shoulder pain for 2 years and no trauma. Okay. And the MRI critical zone near complete full thickness articulars. Well, so that description she did is in itself not correct. So if it's a full thickness tear, it's not articular or bursal sided, then it's a full thickness tear. It's either or. Of the supraspinatus with patellar retraction, infraspinatus tendinosis. Is there partial thickness tear of subscapularis, upper border, biceps intact, interstitial tear, and degeneration of the anterior labrum, or is it normal? So given a 60-year-old patient, you can just say the labrum is degenerated. Let's start with that because nobody cares about the labrum in a 60-year-old patient, so we just go with degeneration. Yeah, so just some sublabel foramen here and then a bit of degeneration of the labrum. So even without looking, just go with a little bit of degeneration. That's totally fine. And I don't see a distinct labral tear and stuff like that. It's just some degeneration and fraying. So that's all I do. But let's focus on the tendons now. That was your actual question. And for that, we need all the pieces we can get. So we can see here, yes, so full thickness tear with fluid signal all the way through. And this is at the posterior part of the supraspinatus by the looks of it. So we follow the tendon from medially. We can see here there's a large tear. We can measure the gap from here to here, like from here to here. Full thickness tear, at least at this location, there is nothing going through. So complete, or not complete, full thickness tear, posterior half of supraspinatus. Infraspinatus upper border comes here. It's maybe involved. So I would probably suggest that the tear affects also the anterior edge of the infraspinatus tendon, as we cannot really follow this tendon nicely down. I think at this level it should have a little bit of a infraspinatus coverage. The anterior portion of the tendon itself is intact. We can see long head of the biceps tendon shows tendinosis and caliber irregularities here, which I want to see also here. We can see it's abnormal. We can see also here the tendon comes up here. One is this aponeuric expansion. We need the sagittal for this now. Yeah, that's too much. So I think I will give a partial tear of the tendon. Subscapularis itself is okay. So subscapularis, a little bit of tendinosis, but it's a broad attachment here onto the lesser tuberosity here, nicely covered. There's no fluid going between tendon and bone. And this is this funny thickening of the tendon here, which has a bit of a interesting appearance because of the angulation. Somehow it's a weird angulation. I can't really see it nicely, but I would assume that this is part of the this triangle. Or is it fat? No, this is not fat. There's no fat up there. Do we have a sagittal T1? No, you can see there's no fat. So I think this is, oh wait, no, this is bone, this one. So here, no, there is no fat in this location. So I think this is part of a flap of the intra-articular tendon. So we can see the intra-articular long end of the biceps tendon has a diameter like this on this slice, and then becomes narrower and dives into this. So severe tendinosis, and then it has a caliber change to this, a very small caliber change to this, and then this one, and then we have this larger bit here, and then the very big stuff here. So I think this is a high-grade partial tear of the long end of the biceps tendon with tendinosis in the interarticular portion. Okay. So I think that answered all the questions. It worked for me. Here my answer. Just for which it's either full thickness or articular. There is no full thickness there, unless you want to say there is full thickness there posteriorly with extension anteriorly into a articular tear, articular sided tear component. So that's another way how you can phrase it, component. So let me give this one, copy, zack. Okay. And good. Shoulder outs 4 hours ago. Okay, we don't need this, and this is by Shabby. Let me just okay, so record. Shoulder out high case. Here is the case. Let's load it up. Woman previously operated with Mumford distal collarbone resection. Distal collarbone. how would you go with the supraspinatus? What is the hypointense zone deposit? Eric's is normal. Would you go? Okay, so let's have a look. What's going on here? So this is the clavicle. What did they resect? Don't see anything that's been resected. I don't see any calcific tendinitis. So let's go here, and apparently there seems to be some low signal stuff somewhere. And she had a procedure. Okay, so the AC joint looks a bit wide, so maybe they just resected a little bit of the parts of the lateral clavicle here, makes the AC joint a bit wide. That's not gonna matter. And I think you're probably thinking about this low signal structure here. So follow the tendon and then go find this area on the T1. If it's not dark on the T1, then this is just the signal of the tendon that sometimes can be a bit weird. So we would not worry about that. So it's not calcific tendinitis. We can rule that out. But what do we actually say about the supraspinatus tendon? So we can see from the medial side, we follow it. We see it broadening up. The anterior portion here is fine. Superior facet is nicely covered. Then we have got some higher signal here at the insertion, at the overlap between supraspinatus and infraspinatus. So there's a little bit of a high signal here, maybe even with an intraosseous, little bit of a cyst or beginning ganglion cyst formation. And so this could be indicating that there is a small footprint or a beginning interstitial footprint lesion. It's not articular sided. We can see it's always covered on the articular side, but I would go with here with a very small, tiny concealed interstitial delamination, which is a CID, which is with intact bursal sided and intact articular sided fibers. But given with the cyst here, I think that's what's happening at this location. And there is tendinosis of infraspinatus and posterior aspect of supraspinatus tendon. Teres minor is fine, subscapularis is fine. Long end of the biceps tendon is also fine. Was there any other question? Yeah, and the low signal, yeah, sometimes the tendon looks a bit funny, and I think this is because here is a higher signal than normal, and then we have a little bit of a of tendinosis combined that makes this stand out, this low signal. And this is a common pitfall for calcification. So the T1 is our best friend to actually solve this. And if you have to the radiograph, actually, like you have in your case, we can already rule that out, or we can now rule it out, basically. Good. So, you'll need this. Okay, guys, so I think we're nearly done. And you see, I think it's a great way to learn. And if you want to learn, or if you want to join, you can easily do that. So we got, okay, let's do the last one. This is the very last one, and then, yeah, if you want to join the fellowship, before we do that, you can just go to onlinemskfellowship.com. You find all the information you need here. You sign up, you can watch a free training. You can find some information here about myself. You can see what other people had, what kind of like results they had. There are many more of these testimonials, but we didn't have time or yet to upload them. So basically you can go here, watch this free training, and you watch this video. I think it's a great video. It gives a little bit of an idea of what's going on and how you can already start getting better. Even without joining the fellowship, there's some 3 secret strategies, like what's the calibration effect you need to understand. We talk about the radiology gap, which you also need to understand, and I'll give you my little trick on how you can start self-calibrate today. And if you like it, if you want to know more and consider seriously joining, go here, schedule this free strategy session. Basically what it is, we analyze your situation, and you can ask all the questions you have about the fellowship. We lay out how it works in detail and what everything is entailed, payment plans and everything, diploma, and you get CME, and we explain it all. It's a 45-minute call, so you need some time to actually have a chat with us. And if you like it, yeah, you can sign up. But let's go to the last case now here. 70-year-old patient, so it's an old guy. Here, let's load it up, and I have to start the recording. Here is the last shoulder case. I think it was a shoulder. Okay, hi Shridut. So we got an old patient, advanced osteoarthritis, osteophyte, subchondral cyst, glenohumeral cartilage loss, loose bodies, massive rotator cuff tear, near complete full thickness tear, supraspinatus with patellar 2 retraction, infraspinatus also torn, subscapularis upper border full thickness torn, biceps torn or intact, degenerative. Okay, so mainly we're looking at the biceps tendon based on your question. Yeah, we can already see advanced osteoarthritis, cartilage completely gone, osteophyte, subchondral cyst, bone marrow edema, even like an old marrow infarction or bony infarct here, vascular necrosis here in the head, and effusion, synovitis, and so on. So biceps tendon is also torn. Like on the coronal, we don't see anything from the biceps anchor going remotely through, but I want to go back here. We can see there's still a slip here, which then becomes thicker. So there is a one stump stops there. There's another slip, but this slip we don't really follow it through. So it's a partial tear with retraction or with different kinds of retractions of these different slips. These are multiple ossicles here. So we got secondary synovial osteochondromatosis here. That's where we should have a biceps tendon. There's nothing. Like this is joint capsule. This is not a biceps tendon. And then there's a slip here, and we kind of like lose it somewhere here. But there's functionally no tendon left. And then, yeah, like you said, subscapularis is, only the lowest portion is going through, the rest is completely torn. And then here, infra and supraspinatus, also supra, they show like these large tears, and also additionally degeneration here, and a lot of synovitis in this low grade, in this low substance things, which is mostly also filled up defect with synovitis. So you can see here all this stuff here, only like these superficial fibers, or some of them are going through, but there will be full thickness components here, and especially the anterior portion of the supraspinatus is torn here. This is posterior half and this is anterior half. Okay, so I think this is it. What did you say? Yeah, near complete. Yeah, that's exactly right. And okay, very good. Nice. So let's see if we are through, but I think that's it. Maybe we got another case. Okay, so that should be it. So now I should have answered all the cases for today. Amazing. Yeah, thank you very much, guys. I hope you liked this video. And again, if you want to join, go here. And if you have any question, you can also message me on school, and I'm happy to answer any of your questions. Bye-bye.